Thank you guys for inviting me here to talk to you today. And I will uh, introduce myself. My name is Katie Norman. I'm an internal medicine physician at Waterbury Hospital, where I'm the associate program director for the internal medicine residency program. So I teach residents who are learning to become internal medicine docs. I'm also the co-chair of the medical ethics committee that we have here at the hospital. So I am frequently consulted on medical ethics issues. Sort of work closely with psychiatry because they're also often involved in these cases as well. So we're going to talk about sort of an interesting topic that I think and hope is relevant. It's a very complicated case, but we're going to address treatment over objection, an ethical approach to patients declining treatment for serious medical problems. So some of you probably have some familiarity with the concept of treating psychiatric illness over the objection of a patient who lacks capacity. And it's similar, but we're going to talk a little bit about how we approach patients who are declining medical treatment that makes the treating team nervous because it seems like it's probably advisable. So this is a real case. Some of the dates are changed. There are no names, but I hope that this is going to be an interactive discussion between me and you guys, because I think talking over ethics problems as a group is what makes this such a fascinating area of medicine. So I'm going to go ahead and get started. So we have some learning objectives. So we're going to learn a little bit about the approach to an ethics consult, and specifically the narrative approach to an ethics consult. We're going to review the 4 pillars of medical ethics. And most importantly, we're going to discuss a framework for assessing the appropriateness of coerced treatment. So when you are proposing administering a medication or performing a procedure on a patient who is unwilling, how you decide if that's the right way to go. And we're going to apply it to a real case. So I'll start with the ethics consult. So actually, our psychiatrist here at the hospital gave me a call on, I think it was Memorial Day weekend a few years ago, and told me that there was patient in the emergency room, the behavioral health emergency room here for decompensated psychosis with probable schizophrenia that had a large ulcerated open wound due to breast cancer that was sort of oozing and bleeding, and she was refusing treatment for that wound, and asked that I, come see her in my capacity as an ethicist, but probably also my capacity as an internal medicine physician. So what's the ethical question? So the first step of any ethics consult is determining what exactly are you looking for? What is the cause of moral distress or confusion that is making the treating team uncomfortable, such that they would like, an external assessment of the situation to help determine the moral or ethical way to move forward. So I sort of narrowed down this ethical question to whether or not the patient's cancer could be treated against her will. And treatment is intentionally vague here because we're talking about lots of different kinds of treatment, right? We're talking about local wound care, assessing for local infection and bleeding, all the way on up to chemotherapy, surgery, those sorts of things. So whenever you have an ethics consult, you need to define the ethical question, and then you sort of need to figure out what questions you need to answer in order to understand the situation, and also who are the stakeholders. What people do you probably want to talk to get the best understanding of the situation and to try to mitigate conflict between different parties. Um, so, so yeah, I'll take a break there. We'll come back. So here's sort of a list of who I identified as the stakeholders. And this is probably the list of stakeholders that you typically see when you're doing an ethics consult or when you're sort of navigating discussions with, complicated cases. You really want to, obviously you want to talk to the patient. Often you want to talk to the patient's family. Among the family members is the patient's next of kin, right? So the person who would be a designated decision maker if there wasn't somebody else explicitly named.
Then there are the designated decision makers that are explicitly named. So these are like powers of attorney, guardians, conservators, things like that. And then the treating provider. So, I'm called by a treating provider. Not only do I want to speak to the psychiatrist about his concerns, but I also want to talk to the oncologist probably. And anyone else who might have some insight into the situation. So what information do I need? So first and foremost, I need to know if she has capacity. We'll talk a little bit about what that means. And if capacity is something that she could gain. So remember, she's acutely psychotic. So she may lack capacity now. Obviously, she hasn't been assessed, but could that change with treatment of the psychosis? What determine specifically what treatment she's refusing, both medical treatment and psychiatric treatment, and also what is the oncologic history and how serious is the disease. So as an internal medicine physician, I want to know not only what treatment has she refused in the past, but how serious is the breast cancer, so that I can kind of weigh the pros and cons of the different treatments that would even be offered to her. So we're going to talk a little bit about her background. So I'll start by describing the narrative approach to medical ethics. So the narrative approach is my favorite approach to medical ethics, and it's really attempting to understand a patient's situation and the ethical question and the decisions that you're talking about in the context of the patient's life, and the context also in the context of the patient's narrative. So in understanding what the patient's been through, the decisions that they've made in the past, things that they've prioritized or valued over the course of their lifespan can help inform making the best decisions you can for them when they aren't able to participate themselves. So I think I'm nosy. I like to sort of know the whole picture and get to know the patient and get to know their family and the dynamics, because it helps to have helps you create a clearer picture of what's going on, so that you can speak, so that when you render recommendations, you're doing it thoughtfully. So this patient, she was in her mid-50s. She had completed high school and some college, and she had worked as a nursing assistant for a few years. She was never a smoker. She didn't drink alcohol and had no substance use history whatsoever. She had two daughters, one of whom is 30 years old, and lives in Texas, and the other, who's a minor, 14 years old. She is estranged from the eldest daughter and has very limited contact with the youngest daughter, who is currently living with her parents. So she had worked as a CNA for a while until the birth of her youngest daughter, when she became a homemaker. When the child was 8 years old, she divorced from her husband, who did reportedly have significant substance use issues, and there were some legal issues there as well. It was around that time that her family noticed that she seemed to become a little bit more disorganized, and I'll be more specific about that in a second. So she has three siblings, two brothers, one sister, and she was raised by her mother and her stepfather. She doesn't have a relationship with her biological father. So she had been largely estranged from her family after several years of failed interventions to help her get mental health care and stable housing. So it was sort of an interesting situation where many people in the family had recognized that maybe something was wrong. It wasn't really named or discussed openly in the family, but many people had tried to intervene to try to get her to accept some degree of help, which she was unwilling to pursue. And so a lot of the relationships fell apart. She did move in with her brother shortly after her divorce, when she moved out of her home, and she lived there for 2 years, but she would have periods where she was very erratic and destructive and decompensated. And so after 2 years, her brother really couldn't handle it anymore, and she was evicted from the apartment. Being parents, were worried about her, and they relocated her to a hotel while they kind of, as a family, decided what they were going to do. They paid for 2 nights of the hotel, but she was forcibly removed because she was behaving bizarrely, was very disruptive, was damaging the hotel room, and the police picked her up from the hotel lobby and brought her to her stepfather's sister's house. So this is the step aunt, who's sort of a hero in the story. So the step aunt was an experienced social worker. She had been working primarily with patients surviving trauma, living through domestic violence. And even though she hadn't seen the patient in more than 10 years, this was sort of her professional skill set, and decided she was going to step in and try to make a difference. We'll talk a little bit more about what happened after her step aunt first became involved, but she ultimately realized the problems were pretty big, and she petitioned the court and was appointed conservatorship when no other family member was willing to accept the role. That's a lot. Let's see. So back to what is the ethical question and who are the stakeholders and what information do I need? So now we've learned a little bit more about what people I might be interested in talking to, right? So of course there's the patient and then the patient's family. So I've included in here in the the two children, the siblings, the her mother and stepfather. Her next of kin of these family members is going to be her only adult daughter. But there is a designated decision maker who is the step aunt who was awarded conservatorship. Treating providers that I probably want to talk to are any oncologist she's seen and the psychiatrist. And the rest of these questions over here are things that I still need to figure out. So a little bit about her medical history. So I will there's some medicalese in here. I will explain it, but she reportedly told her mother about 10 years before that she had had some kind of abnormal mammogram and maybe had breast cancer. This wasn't corroborated. I don't have records of this, but that was what was reported to me by the family. 10 years after that conversation with her mother, she was formally diagnosed with breast cancer in 2020, when she was found to have a palpable mass on her left breast. So she felt a lump. It was biopsied and it demonstrated hormone receptor positive, HER2 negative breast cancer, which is a breast cancer that has some good treatments associated with it. ER/PR positive breast cancer is something that you can treat with some hormone blocking therapy and have a good result. She did not complete the staging evaluation. So anybody who's worked in clinical medicine or who's had family members with cancer, which is unfortunately many of us, know that you have the diagnosis, but you're by the biopsy, but you're not done there, right? You need to go and get PET scans and CAT scans and MRIs and things like that to figure out, okay, we know that there's cancer here, but has it spread anywhere else? And based on that information is how you determine what the stage of the cancer is and what the best treatments are. So she never completed the staging for the cancer and was lost to follow-up for another 2 years. In 2022, when she moved in with the step aunt became aware of a large ulcerated exposed mass on the left breast. And to be quite honest about it, it was mostly from the smell of the wound that was sort of festering there. The step aunt was able to get her to an emergency room where she had a CAT scan, and initially have her established with an oncologist who was local. So the CAT scan showed that she had some lymph nodes under her left arm, but it didn't look like there were metastases or cancer spread to the bones, the lungs, the liver, the places that you worry about in somebody who has breast cancer. She refused to have a PET scan, so it was never 100% clear that it hadn't spread, but it seemed like it was probably somewhere around stage 3, a locally advanced cancer that had spread to the lymph nodes, but probably not anywhere else. She was started on 2 oral medications to help control the breast cancer, that tamoxifen and palbociclib, which are both, like I said, they're both oral, they're not infusions, and they're both, frankly, fairly well tolerated. Some people are on these medications for years and years. And she was referred to a wound care specialist to sort of clean up the wound. It was extremely challenging to maintain treatment adherence for this patient, to say the least. When the medical transportation would arrive to bring her to appointments, she would literally run out of the house and hide into the woods. She didn't feel that she had cancer. She felt like she was somewhat paranoid about the cars coming to pick her up. She often wouldn't take her medications, though occasionally would go through periods where she was adherent. She often wouldn't adhere to the wound care, and the police were called a number of times to sort of get her into the car or help de-escalate situations when they became hostile. So by spring 2024, she had stopped taking her medications entirely, and she stopped following up with her oncologist. Her step aunt was unable to keep doing it. So by the time I saw her, it was now fall 2024. I was able to identify her oncologist and give him a call and sort of find out where everything stood, which were, and he told me that at this point, she likely has stage 3 disease. The goal for her therapy would be to certainly reduce the size of that mass, which was certainly painful, ulcerated, high risk for infection and bleeding, that her disease probably is not curable. It may have been curable in 2010, but is not curable now. And he said that the treatments were good, that her life could be extended by a few years, presuming that there still was no distant metastasis of the cancer. All right. I also spoke with the breast surgeon who had evaluated her in the emergency department over the summer. And the breast surgeon essentially said that the cancer was too big, that it was too late to do a procedure to remove the breast and clean up the wound. The problem being that when you go in to do surgery, if the tissue itself is sick, if the tissue is cancerous, it will never heal. They would never be able to close up the wound. And so their recommendations were local wound care, chemotherapy to try to reduce the size of the mass, and potentially radiation to help it, but that surgery would actually do more harm than good. So interestingly, about her psychiatric history, she had never been hospitalized for a psychiatric reason in the past. She was described as having been weird in high school. Those were the words that her family used, often talking to herself, but was never formally diagnosed with a psychiatric disorder prior to when she returned to Connecticut after her divorce 6 years ago. She had never taken an antipsychotic or any other psychiatric medication for any period of time, and she had never followed with a behavioral health provider. So they suspected she had something like schizophrenia based on ER presentations, but she had never had a longitudinal relationship with any sort of behavioral health. And it speaks to what I suspect is a family unwillingness to acknowledge what this was for a little while, and also to her estrangement and her limited contact with the family over the years. So back to the ethical questions. So we have identified the stakeholders. We know what we're asking about, which is whether or not we can compel treatment for her breast cancer, because now we know the breast cancer, that treatment might actually help her. She could live longer. She could, control some of the really awful symptoms related to this mass on the left breast. So what information do we need? So question number 1, 2, and 3 is, does she have capacity? Can she participate in a conversation with us about what she wants for this in this situation? So capacity, as you probably know, is decision dependent. Someone might have capacity to make one decision, but not capacity to make another. For example, you have a patient with mild cognitive impairment or early dementia. They may be able to decide whether or not they want, let me see, something straightforward, whether or not they want pain medication, or whether or not they're willing to undergo biopsy procedure, sort of a basic procedure, but they may not be able to manipulate more nuanced and complex decisions like chemotherapy or with in the setting of chronic illness, like dangerous decisions where you need to be able to manipulate nuanced, complex, and sort of changing information. The next question, which I am unable to answer, but I did talk to her, the psychiatrist, about, was, could she gain capacity? So maybe she does not have capacity to make decisions regarding chemotherapy for the breast cancer, for example. But could treatment of her psychiatric illness help her to get to a place where she could make decisions and could meaningfully participate in those conversations? It's a little complicated, right? Because she was determined to lack competence by the court. So competence and capacity are two different things. Competence is a legal definition by which someone might be assigned a conservator in the court, and capacity is really based on a medical assessment of your ability to manipulate information and make informed decisions. And having a conservator does not negate the need to assess a patient for capacity. So what treatment is she refusing? So she's refusing psychiatric care. She's refusing oral chemotherapy and hormone therapy. She's also refusing wound care. So I know at least that. And then the last question, how serious is the cancer? The breast cancer was probably found at a very early stage. It was definitely incompletely staged, and it was certainly incompletely treated. We know that surgery is no longer an option. And we know that based on the last imaging, it was at least stage 3. I'm going to tell you a little bit about the patient. And then we're going to take a break in a second to sort of answer any questions and talk through your thoughts. So I call her Lenora. After a girl I knew in college who she looked like. But anyway, so Lenora had told me that the breast cancer began as an insect bite. She didn't believe it was cancer at all. She stated that if she did have cancer, she wants to be comfort measures, and she asked me to respect that. She had very poor eye contact. She was rambling, would sometimes answer questions appropriately and other times make bizarre and inappropriate statements. So in between, for example, she would tell me that I would read about her in the history book someday because she had discovered the cure for AIDS. That there's nothing wrong with her left breast. It's an insect bite. She just needs Tylenol. When I asked what her understanding of comfort measures would entail, she explained accurately a comfort-based approach. She described to me hospice. She described to me IV morphine, sort of the medications we use for palliation in someone who's end of life. She said no more doctors or chemo or hospitals. But then the most important question, when I asked her what will happen if the cancer is not treated, she sort of smirked and expressed that she didn't think she had cancer at all, and that it was a leading question. But she did answer that when God calls her home, she will go. She referred to religion quite a bit over, in her interviews. She was very pleasant and calm in the interview. She, like I said, poor eye contact, bizarre, inappropriate rambling, but very nice and respectful. She was able to tell me that she had seen an oncologist in the past, and she, quote, took his drugs. And when asked about her mental health and how she's coping with the diagnosis and whether or not she hears things other people don't hear, sees things other people don't see, she was a little upset and expressed that this was not a psychiatric issue, that we needed to respect her decision, and that she has a terminal disease. So when asked what terminal disease, she was unable to answer. So quickly, the 4 pillars of medical ethics, you guys may be familiar with this. So these were described a few decades ago by Childress and Beauchamp, who are famous medical ethicists. And really, it's the 4 pillars are beneficence, which is when you're taking care of patients, you do what's in their best interest, what benefits them. Non-malfeasance, do no harm, probably the first medical ethics principle that was ever described. Autonomy, patient autonomy. You respect the patient's rights, preferences, and values, even if they disagree with your own. And then justice, which has a lot to do with just and equitable distribution of resources. So what do you guys think? She doesn't want psychiatric treatment. Can we give her antipsychotics against her will? She doesn't want diagnosis or staging of her cancer, scans and biopsies and so forth. Can we do that against her will? And she doesn't want cancer treatment. So could say we do all of this diagnostic workup and she has treatment options. Can that be done against her will? I'm sort of curious what you think. And there aren't wrong answers, so don't be shy. I can be very comfortable with silence. I teach residents.
Feel free to use the chat. Oh, you have a question.
Yes, so she is still living with the step-aunt. Yeah, the question is she still living with her step-aunt? And she is. And she is a churchgoer, correct. She's very religious. I'm reading that we'd have to respect her not wanting medications, even if it means she'll die from cancer. Even if it means she'll die, yes. So that is the meat of this conversation. So we don't respect people's wishes regarding medications sometimes, correct? You know, you have a patient with dementia in the hospital who is thrashing around in bed. How many of you have seen such a patient receive IM Haldol, Benadryl, and an Ativan? You see a patient with psychosis who's unable to demonstrate capacity. How many times do they receive depot antipsychotics until such a time that they're able to participate? You know, there are exceptions that are made, but what you're pointing out is a really good point, that autonomy is one of the most valued of the 4 principles of ethics, particularly in this country. And a lot of weight, probably because historically, you know, doctors made a lot of decisions without caring a whole lot what their patients thought. You know, even actually up until the early 1960s, it was pretty common for doctors to not even tell their patients if they had cancer, if they felt that they weren't candidates for treatment. So respecting patient autonomy and allowing them to make their own decisions is often paramount, but it is not absolute. So I'll tell you a little bit about the stakeholder. Would she trust a minister or priest for some of their thoughts from him or her? So that's an interesting point. So we did have the chaplains come and see her. She didn't was unable to tell us the name of any particular minister or priest. She liked having the minister come to see her quite a bit, but she was unwilling to talk to him about any of the medical issues. And she again, it was this theme that she didn't believe she had cancer at all. And that it was she kept referring to it as a charade. But that's a good point. So I can tell you her family, and including the conservator, right, who's the legal decision maker, really wanted her to be treated. She has a 14-year-old daughter, remember? And this 14-year-old child would come into the hospital and would sit on the edge of her bed and cry and ask her mother to please take the meds. She wanted her to be around. Her family was clearly struggling with the fact that this is a treatable, if not curable, disease, that it was once a curable disease, and felt very strongly that if only we could fix the psychiatric issue, she would understand and she would want to be treated as well. In fact, they went as far as to file a petition with the Court of Probate to try to force antipsychotic treatment for her, sort of at the same time that this was happening. So you can imagine how much the family was struggling with this. She's a young woman. She has no other medical problems. She has a minor child. and potentially treatable disease. So I'm seeing, from a psychiatric standpoint, she doesn't seem to be at imminent risk, but an argument could possibly be made for grave disability. Aha! We can't force psychiatric medications in Connecticut outside of a hospital setting, so the decision of whether she meets inpatient criteria would need to be made first. Exactly. But regardless of her psychosis, she seems to be able to appreciate the risks and benefits and is making preferences pretty consistently clear. So all of that are things we're going to talk about. So coerced psychiatric medication, right. So the question is she an imminent danger to herself or others, or is she gravely disabled? So it's that perfect timing on that comment. So she is not actively suicidal and not a danger to others. And grave disability refers to her ability to obtain food and water, to feed herself, to clothe herself, and to obtain shelter. And she, though largely through the availability of her step-aunt, has not demonstrated that she is unable to do any of these things. So by the psychiatric evaluation, she did not meet criteria for grave disability at that time, though she was, or that she was an imminent danger to herself or others, such that they felt comfortable administering antipsychotics against her will. Part of the problem was now that she was here, her family was unwilling to take her home and there was no safe discharge. And I think that was sort of how she had remained in the behavioral health emergency department at the time that I evaluated her. Because you're right, if she doesn't meet one of these two criteria, she shouldn't be admitted necessarily. She did, yes, she did say if God calls her home that she would go, that an understanding that she could die, right? But she also couldn't express that she understood that she was dying. So if the question is leading such that you're suggesting, if this cancer were to kill, if you had an incurable disease that would kill you without treatment, which was not something she was willing to which was not something she was willing to accept. She said God will call her home and she will go. So we're going to talk a little bit about how you come to conclusions about treatment over objection from a medical perspective, because you guys are probably much more familiar with how you do it from a psychiatric perspective. Rubin and Prager, who are also pretty important medical ethicists, actually Prager is like 80 years old and he practices at Columbia, developed sort of this series of questions that need to be explicitly answered in order to justify a decision. So the first question is, how imminent is the harm without intervention, right? So if someone comes in with a gunshot wound, you're sort of given a blank check to go do whatever it is you have to do to save that person's life, because there isn't a whole lot of time to weigh the rest of everything else. Then there's the risks and benefits. What is the likely severity of harm without intervention? What is the efficacy of the intervention that you're proposing? What are the risks of the intervention that you're proposing? And what are the logistics of treating over objection for this patient? And then finally, there's respect for persons, which is what is the likely emotional effect of a coerced intervention? And what is the patient's reason for refusal? So to give you a few examples, you might think having a coerced treatment is going to be emotionally traumatic regardless. But if you imagine the patient who is confused or encephalopathic related to, say, needing to have dialysis, to toxins building up in their blood from end-stage kidney disease, they may not be able to understand why they need to be dialyzed, and treating them over objection may be difficult initially, but once you dialyze them, they may be grateful that they were dialyzed because now they are clear-headed and can participate in a conversation. What are the reasons for the patient's refusal? Even if it's a delusion, an unwillingness to accept the truth, you need to understand what it is the patient believes or values that they are refusing. And this is where the narrative approach can really help. And then the risks benefits, this really gets into consent that's obtained for anything. What is the likely severity of harm without intervention? Back to my example of the patient with a gunshot wound, the severity of harm without an intervention is death, right? So that's pretty severe harm. The severity of harm without intervention for, what's a good example? It's very harm without intervention for a blood pressure medication when the blood pressure is borderline. It's probably not particularly significant, right? Like there is harm. Everybody's blood pressure should be controlled, but it's not immediately life-threatening. Of these questions, there are two that have been studied and have been found to be the most persuasive for clinicians. So does anybody have any idea what two those might be? Give you a couple minutes. So the two that are most persuasive and seem to carry the most weight are, one, how imminent is the harm? It sort of forces you into a corner, right? If something is emergent, you have to make a decision. And also, what are the logistics of treating over objection? How hard is it going to be to administer this treatment? For the example, the dialysis example, it's one thing to say if dialysis is a very effective treatment, if you put somebody on dialysis, it works pretty well. We have a lot of experience doing it in healthcare, but what you're talking about is needing someone to sit still and quietly for a prolonged procedure, potentially needing to sedate them in order to perform that procedure, needing to transport them to and from a dialysis unit, and quickly, so what might be the right thing to do in theory, quickly on further consideration can be apparently very cumbersome. So the logistics of providing the treatment that you're recommending can be really persuasive regarding whether or not you're going to pursue it. So we'll look at the two major problems that this patient has under this framework. So for chronic psychotic illness, so they're calling it schizophrenia. We don't know if it's schizophrenia. I'm certainly not qualified to diagnose it. But what is the urgency? What are the risks and benefits? And regarding the respects for persons, the emotional side effects of treating her psychotic illness, and the understanding the patient's reason for refusal. And I think to Nicole's point about imminent risk, grave disability, et cetera, I'll just go ahead in the interest of time. This is her chronic psychotic illness is not urgent without imminent harm, and she's not gravely disabled. She's not a danger to herself or others. So the issue of urgency is sort of put to bed. There is measurable harm for not treating her condition, right? She's unable to hold a job. She's unable to maintain relationships with her friends and family, notably her children. She's unable to interact productively with society to provide for herself. There is effective treatment available, though the degree of efficacy is imperfect, right? Depending on what ultimately she's determined to have, what medications are prescribed to her, she may or may not, her response is variable. Certainly, this is not curable. The risks of intervention, including things like, the metabolic syndrome associated with psychotic disease, bone marrow suppression, antipsychotics, bone marrow suppression related to some of the more powerful antipsychotic meds. And then the significant logistical hurdles of trying to administer medications to a patient who is frankly unwilling to take them. Are we talking depot administration, IM administration, trying to persuade her to take something orally? These are all things that need to be considered. And then finally, there's likely going to be significant emotional distress and trauma. It's unlikely that you will start treating her and she will suddenly realize that she hasn't been thinking clearly and is grateful for the treatment. In this case, this has been sort of a lifelong condition for her. She does not believe she has a psychiatric disease. And if you take a moment to put yourself in her shoes, you can imagine how traumatic it is for someone to administer, an antipsychotic medication when you don't feel you have an issue, and what a violation that is of your human rights. So we probably can't give her an antipsychotic against her will, right? I think we can all agree that that's That's not fair. That's not right. So her advanced breast cancer. So what's the urgency? What are the risks and benefits? And respect for persons. What are the personal and emotional consequences of treating her advanced breast cancer? So it's non-urgent, right? And it is without imminent harm. It is certainly a terminal illness, but it is not an emergency. She could foreseeably survive weeks to months without any sort of intervention whatsoever for this. So we have time to sort of weigh the pros and cons. There is severe harm. This is a terminal disease, and not only will it kill her, but it will be horrifically disfiguring, as it already is. There's risks of infection, significant blood loss, bone mets and bone fractures, brain mets, etc. So the harms are innumerable and they're serious. The efficacy of the treatment is a question, right? If we knew for a fact that she had stage 4 metastatic breast cancer, then we could have an informed discussion about how efficacious the treatment is under those circumstances, but we don't. We do know that breast cancer can be among one of the more treatable cancers. We do know that at one time the breast cancer was hormone receptor positive, and there were treatment options that were oral medications that could potentially seriously slow the rate at which the cancer was growing. But we do know that there are serious risks of intervention. So if she truly has stage 4 disease and would require IV chemotherapy, like platinum-based chemotherapy, the sort of meds that cause hair loss and bone marrow suppression and risk for infection, those are not small risks. There's some major risks associated with that treatment for anybody. And then there are significant logistical hurdles. To administer chemotherapy to a patient, would you sedate her for each dose of chemotherapy? Would you restrain her to get her to a cancer hospital? How would you be able to keep her still for radiotherapy? Again, sedation and restraints. Surgery is not an option, but wound care. How are you going to clean that wound, debride that wound, dress that wound? And then there's significant emotional distress and trauma with this. She does not understand that she has cancer. She does not understand why the treatments proposed would be enacted upon her. And she has made her feelings known, even if she can't demonstrate a complete understanding of her illness. So at this point of the game, I agree with you guys. We can't give her an antipsychotic. We can't force her to undergo diagnostic testing with CAT scans and PET scans and so forth. All of those would be completely unusable if she's moving around during the scan. And we can't treat her for cancer even if we could complete the diagnostic testing. So 2 weeks later, she was still admitted to the hospital and I was called back to see her. At this point, she was worsening. She had waxing and waning psychotic symptoms. She was pacing around her room, was felt to be acutely delirious. She was speaking to people who weren't there in the room. She was writing furiously down what she felt she was hearing from demons and angels that were talking to her. She was intermittently disoriented, consistent with acute delirium. She also had increased and significant bloody drainage from the breast wound. So the wound itself probably encompassed 2/3 of the left breast. There was a lot of exposed fat, exposed blood vessels that were bleeding, clotting, bleeding. It was oozing pus and blood and serous fluid, and she had evidence of dehydration as well as significant anemia related to the blood loss of this wound. She remained adamant that she not receive treatment of any kind for anything. Did not believe that she had cancer, did not believe that she had psychotic symptoms, and did not believe that she was anemic. She felt that the only medication she would actually accept was Tylenol. And though I will say she was calm and pleasant to talk to, she was never violent or aggressive. So the question again was, are there treatments that can be ethically administered over her objection? So if we use the same criteria, what do you guys think? Is there anything that we can do for her at this stage? Say she's pacing around the room and she is making threatening statements to the staff. So in the interest of time, we have the two new problems in this circumstance are acute blood loss anemia. You know, I'm an internist. I'm going to start with the major medical problem here. What is the urgency of this? What are the risks and benefits, and the respect for persons? So acute blood loss anemia is urgent with imminent harm. If you're bleeding significantly, you need to do something about it, right? Depending on what the threats were, if she was actively expressing, she would harm herself or someone else, right? So an acutely delirious person who is believed to be an acute threat to themselves or others, then you could potentially administer something, essentially a chemical restraint. Great. So for acute blood loss anemia, there's imminent harm to bleeding. We know that if she continues to bleed and we don't intervene, there will be severe harm. You can die, you can have a heart attack, you can have a stroke, you can cause kidney injury. We know what to do when someone needs blood. We give them blood. It's very effective. The risks these days are minimal, particularly if you've never received a transfusion before. The likelihood that there's some antibody that you have that we don't test for is almost zero. But there are significant logistical hurdles, right? We would need to be able to obtain another blood sample. We would need to send it for type, cross, and screen. Then we would need to be able to gain IV access to administer the blood over the course of 4 hours per unit. And then we would need to follow up with a subsequent blood level to make sure that we had achieved our target. There would be significant emotional distress and trauma. She doesn't want it. We would likely need to sedate or potentially restrain her in order to accomplish this. And her reason for refusal, which is important, is that she does not believe she is anemic. She feels that this is unnecessary. So for the acute delirium is a geriatric emergency. It is urgent. There is imminent harm. I think there's probably few things that are more terrifying than being completely out of your mind and unable to engage with the world around you. You know, when you take care of patients who have had extended hospital stays in both an intensive care unit or elderly patients who are in the hospital for a prolonged period of time, and you talk to them once the delirium has subsided, you hear these terrible stories of sort of coming in and out of awareness and not understanding what happened to them and feeling like they were being persecuted, despite the fact that now in hindsight, they realize they were receiving treatment that saved their life. It's well documented. There are a lot of studies these days related to PTSD from the delirium that is associated with an intensive care unit admission. And acute delirium is associated with increased mortality, certainly among elderly patients. We take it very seriously for a reason. There's severe harm. You know, that's a great question. So I'm asked, how does the step-on come into decisions for this situation? And we will get there. So there is severe harm related to not treating acute delirium for all the reasons that I mentioned. There's minimal risk of intervention. You know, the interventions are something like an antipsychotic medication, and then some less invasive treatments like leaving the windows open to natural light, gently reminding the patient of time, place, etc., encouraging family to visit. But there are some logistical hurdles, right? Administering a medication over someone's will, IM or IV, is not simple. It causes significant emotional distress at the time and trauma at the time, though if it helps the patient to regain insight into their situation, that is mitigated. And her lack of insight speaks to that. So regarding the decision maker, so the aunt felt very strongly that as the conservator, these were her decisions to make. And I think that that is a commonly held misconception, that once you're a conservator, you are legally that person's decision maker and you get to call the shots. And while that is true to some extent, that a conservator, much like a guardian or a parent, has the legal authority to sign for consent, for example, you are entrusted with the power to make those decisions on the understanding that you consistently involved the conservatee, the person who is being conserved, in decision making. And the court of probate can be petitioned over and over again by the person who is conserved if it is felt that the conservator is not taking their wishes into account. You can't simply make a decision that you think is right without consulting the patient in particular. And even if, and which is what they try to do, they did try to go to the court of probate and try to make an argument that she should be treated over her objection for her psychiatric illness to facilitate subsequent treatment over objection of the cancer. But just because legally there may be some protections in that, which arguably there are probably not, that doesn't mean it's the ethical thing to do. And I think it was complicated here by the fact that her family was so distressed by the situation that they were in, and they just could not fathom letting nature take its course. So yes, so for any intervention, say we were to pursue a blood transfusion, you would need the consent of the conservator to do that. But the conservator can't unilaterally and without exception demand that something be done if it is unethical. I hope that answers your question. So the recommendation of the ethics committee was that at the discretion of the treating physician and the patient's conservator, it's appropriate to treat her acute delirium over objection with antipsychotic medications. This is an urgent issue. The harms can potentially be mitigated by improving her ability to participate in her own decision-making. And this is a potentially curable condition. At the discretion of the treating physician and the patient's conservator, it is appropriate to treat her acute blood loss anemia over objection. This is an immediately life-threatening condition. She is delirious and unable to participate at all. This is something that you could potentially apply more heroic measures to treat. And you'll notice I say here at the discretion of the treating physicians and the patient's conservator. So the step-aunt does need to be consulted in these decisions, but it's an ethical decision. It would be ethical in order to take that course of action. Third, the decision to attempt treatment for her advanced cancer is appropriately on hold, and without unexpected significant improvement in her ability to adhere willingly to treatment, it is not a viable option. The ethics committee felt very strongly that it was unethical to try to force treatment and enforce evaluation of the cancer, considering what a logistical nightmare it would be and how traumatic it would be for her, and with unknown benefit. And the treatment for her chronic psychiatric illness at that point was on hold given her acute delirium. And forcible chronic antipsychotic therapy poses substantial harms, unclear benefit, and significant cost to personal dignity that would need to be accounted for prior to any decision. This is, and then finally 5 is, ongoing communication. This is evolving, right? Preferences can change just as a patient's condition changes, their treatment preferences, their goals of care, those things change too. So it's not simply something that's decided once and completely, not addressed again. I think probably the cancer issue is not something that would be addressed again because there is a time-sensitive component to deciding to pursue treatment. But these are somewhat fluid situations. So the outcome for this patient. So her delirium improved with temporary antipsychotic medications, which were ultimately discontinued. She ultimately did accept oral treatment for the acute delirium. It wasn't really consent, it was assent, which, the nuanced difference being she didn't want to do it, but she was willing to take the meds to avoid having a coerced IM injection. So it was administered IM on only one occasion. She did accept 1 unit of blood, and that was okay. So she assented to 1 unit of blood, and she ultimately did agree for a CAT scan. And it was found that she had significant pulmonary metastatic disease. And, while that information did not change the patient's decision regarding foregoing treatment for her cancer, we were able to take that information back to her family and, most importantly, her children, and explain that, we have now reached the diagnosis that we thought we were dealing with, which is stage 4 incurable disease with very limited treatment. And the treatment that we're talking about is extremely dangerous, with a lot of side effects, and would be very hard to administer. So getting those staging CAT scans really did help inform the goals of care and bring everybody to the same page and reduce some of the moral distress that they were experiencing. She was ultimately discharged on hospice care. I believe she was first in some sort of a group home, and then ultimately went to live back home with her family. And she died 9 months later from widely metastatic breast cancer. So here are some of my sources that I used. I don't know if anyone listens to medical podcasts. There's one, it's free, it's called Core IM, and they have a couple of podcasts called At the Bedside related to medical ethics issues. And they're really very good and thought-provoking. And these are some of the major essays that have been written that talk about these issues. And that's all I got. So I want to hear your guys' thoughts or questions, all of that. Okay, well, if there are no questions, I'm happy, if you want to make my contact information available, I'm happy to send links to the resources that I provided, maybe answer any questions anybody has in the future, point you in the direction of more resources if this is a topic that interests you. And thank you guys very much for inviting me.